look at suicides in the United States, there's 40,000 suicides a year. That's twice as many as homicides. It's one of the leading causes of death. But the stat that jumps out at me are two. There's 64% of these patients saw their primary care physician a month before taking their life. I think stigma played a huge role of them not asking for help, but 38% saw a healthcare professional within 7 days of taking their life. One study says 70% of primary care physicians feel that all their appointments are psychosocially related.
The struggle in primary care is trying to manage the medical problems of a patient when they also have an underlying behavioral health issue. It is difficult to manage the medical problems and then enter the realm of behavioral health.
So I think it starts off as to why we started the Behavioral Health Integration Program. Long story short, it's a way to improve psychiatric access to where the patients are. We want to meet and support primary care providers and their patients in their clinics. It gives us an opportunity for our team to see these patients while the provider is able to keep going and see their own patients at their other rooms. When we look at the process, one of the things that we took into account is try to make it as simple as possible for the clinic, be minimally disruptive to the provider's flow in that facility. We have to make it as simple as a phone call and an acceptance of a video. Let everything else fall on our team. That way the primary care physician can focus on what they need to focus on, which is patient care.
So the ability to provide the service in behavioral health while the patient is sitting in your office, while they're captive, and while they have had the courage to open that door with their primary care physician is just a golden opportunity that we're now able to execute. And when we take care of that part of the patient, it's a whole lot easier to manage their medical problems.
We screen for depression primarily because depression is the most common mental illness. But what we tell our providers is the referral criteria is if you wish you had someone there, give us a call. We don't focus on just depression, we focus on any mental illness that the provider needs support on. We have an extensive callback protocol. Most of the times if a medication was started or if the patient had unfortunately negative thoughts of wanting to hurt themselves or hurt someone else, we follow up with that patient within 24 hours. And we want to support them through that process. And we also call them in intervals of 2 weeks. During this time, we're assessing, providing psychoeducation to the patient, seeing how they're doing with their medications, are there any side effects, but all the time staffing these patients through our twice-a-week treatment teams and making further recommendations.
It really is an amazing service, and it is so little time added to the provider. It actually just gives you time back, and I would say embrace it, give it a chance. If you have any questions about it whatsoever, come follow me around for a day, and I will show you how amazing it really is.
I think it's made primary care providers feel reassured that when they open Pandora's box to mental illness, there's going to be a team there. Many providers have told us that they feel that it has sped up their practice, primarily because they can continue to see all their patients that are scheduled while a professional team is seeing their behavioral health patients.
Jump in with both feet and embrace this.
So why do we do this? Why do I think this is important? Is if we can save a life, this pays for itself.